Endoscopic ultrasound-guided fine needle aspiration of 2 cases of right atrial masses. EUS-FNA has spread worldwide due to its accuracy and safety profile in avoiding intervening vessels. Nevertheless, EUS-guided procedures on the vascular system, mainly regarding gastric varices therapy, have been increasingly reported. However, few EUS-guided cardiac interventions have been published. The potential risk of EUS-FNA are hemorrhage, cardiac tamponade, infection, and arrhythmias.
Transvascular biopsies require fluoroscopy, a vascular access, and an esophageal echocardiography to guide the biotome into the lesion, which could be cumbersome to obtain. Adverse events associated to transvascular biopsies could be tamponade, arrhythmias, valve damage, and embolization. Cardiac EUS-FNA advantages over transvascular biopsies could be faster and real-time targeting and punction, avoiding damage of cardiac valves or coronary artery without fluoroscopy. Careful EUS examination after cardiac EUS-FNA carries out pericardial effusion.
The examination starts positioning the echoendoscope into the proximal stomach. With rotating movements, the hepatic left lobe and the hepatic veins draining into inferior vena cava can be observed. In the lower and middle part of the esophagus, with slightly movements angulating the tip and withdrawing the echoendoscope, the left atria and the interatrial septum, the pulmonary trunk and the aorta, as well as the atria ventricular valves can be displayed. More deeply, the right atrium and the right ventricle could be observed. The EUS-FNA of the right atrium is performed with the echoendoscopy positioned in the distal esophagus. The punction has to be performed in a right angle to the esophageal wall, transversing the pericardium and the left atrium. Torque and up and down movements have to be avoided in order to minimize the risk of tearing the esophageal and cardiac walls. We herein report on 2 cases of EUS-FNA of right atrial masses using 25 gauge needles with rapid on-site evaluation by a cytopathologist. Written informed consent was previously obtained after fully discussion with the patients and the relatives on the procedure and its alternatives.
Patients were referred by cardiologists present during the procedure who were in charge for the clinical outcome. Cardiovascular surgeons were on standby. The procedures were performed at the endoscopy suite. Patients were sedated by an anesthesiologist without endotracheal intubation and sent to the post-anesthesia care unit.
A 62-year-old female was admitted for dyspnea and congestive cardiac failure. MRI and CT scan images showed an 8 cm right atrial mass arising from the interatrial septum and invading the inferior vena cava.
Combined PET-CT fusion images displayed an intense hypermetabolism lesion suspicious for a malignant tumor in the right atrium.
An intravascular biopsy was not feasible. EUS-FNA was performed by using a 25 gauge needle in one pass. Here we can see a mass located on the right atrium. Here we can see the tip of the 25 gauge needle and how the needle is going through the left atrium. Now several smooth passes are made. The cytologic and microhistology showed a large B-cell non-Hodgkin malignant lymphoma positive to CD20. Chemotherapy was started with initial response at discharge. The patient died 4 months later due to pneumonia and granulocytosis. A 31-year-old male was admitted for dyspnea, coughing, and hemoptysis. CT and MRI. Large mass heterogeneous with necrotic areas and non-homogeneous contrast enhancement arising from the right atria infiltrating the tricuspid valve. Intravascular biopsy did not yield diagnostic material. EUS-FNA was performed using a 25-gauge needle in 3 passes. We can observe here the right atrium mass. This is the first puncheon in which we were unable to obtain diagnostic material. We were unable again to obtain diagnostic material on our second puncheon with a new 25-gauge needle. Due to the need in obtaining pathologic diagnosis on this patient, we decided to make a third puncheon with again a new 25-gauge needle. The last cytologic smear showed few non-typical fusiform cells embedding in a myxoid background, suggesting atrial myxoma. The patient was considered unfit for surgical resection and he died 4 months after the EUS-FNA due to pulmonary embolism. In these 2 cases, EUS-FNA of the right atrial masses were performed safely without adverse events. Even in the second case, where 3 passes have to be performed to obtain the final diagnosis, EUS-FNA of the heart helped in the clinical making decision algorithm.